Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dulce Simons Family Studio. Today begins our week-long journey into all things vaccination. After this week, you will be graduating from the School of Vaccinology, and you can declare yourself a vaccinologist. But first, you have to listen to all the broadcasts this week, because we're going to be focusing on what vaccines mean to you and whether or not the COVID-19 vaccine is going to be a good thing or a bad thing. A very good thing, in case you had any questions. And today we have a couple of experts. One is Dr. Matthias Salate. He's been with us before. He's a pulmonary physician, and he's the chair of internal medicine and the vice chancellor for research here at the University of Kansas Health System. We welcome Matthias back on the program, as well as Dr. Kevin Alt, an OBGYN physician and an infectious disease physician and a member of the CDC Advisory Committee on Immunization Practices, an individual who has spent his life doing research and work on vaccinations. But first, Hawkeye, Medical Director of Infection Prevention and Control.
Yes.
How do we do over the weekend?
We're doing pretty good. You know, it is a Monday, but I would like to say that we have a bright spot on our Monday.
Yes.
Not only with the numbers, but we did receive a nice thank you for everybody here at the health system and everybody doing health care and working to keep people safe. This is from Edie and Olathe, and it was a very nice thank you letter. So thank you very much. It's well appreciated.
Yep, thank you, Edie.
We need it every day. We need all the encouragement because it's tough, and we know COVID is hard on a lot of people for many different reasons. So thank you. But the numbers otherwise are pretty good.
I got to stop you. Pretty good is all relative, because before when we were at 37, we said, man, that's really bad. And today we're down a little bit, and now we're calling that pretty good. So.
Right. And I was going to qualify because 2 weeks ago we had 100 people of acute infections in the hospital. So now we are down to almost 80, 82. So creeping down further and further is always better. 82 in the hospital with acute infections, 47 of those, though, are in their ICU, and 28 of those are on the ventilator. So still a large proportion in the ICU and on the ventilator itself.
Yeah, because that 27, 28 thing, that's staying pretty stable as far as the numbers on the ventilator. And as a lot of the ones who are here are in the acute phase or in the ICU, so that's tough.
Yeah, absolutely. And we have 59 who are in that recovery phase as well. In Hays, their numbers, again, relatively are a lot better. They were up at 40. They are down to 25 patients in the hospital. 20 of those are active and 5 of those in that recovery phase. So that is better as well. And if we can cross our fingers, we're still just, over a week away from that Thanksgiving, a little bit longer. So hopefully any surge that occurs will be very minimal, and then hence the hospitalizations will be minimal too.
So Huck, why do you think the numbers have gone down a little bit?
Initially we felt with that Thursday, Friday, Saturday, Sunday, it was testing. I think the testing has probably ramped back up. We don't know that for sure. But hopefully people were doing other safe things and meeting in safe manners and even wearing masks in the household and staying distance, or not meeting with other people who are not normally in their households.
Maybe too, I think we believe that some of the impact of schools reopening wasn't the school itself. We're saying people have done a great job, but rather maybe some of the after parties or the social gatherings. And it took 6 to 8 weeks to really measure the full impact of that, because it's not in the 20-somethings that you really measure. It can be. It's really in 30, 40, 50, 60-year-olds that you begin to see it. So it may be the Thanksgiving the time periods will just take us a while to really get to know a little bit more about what happened with that. Yeah. So we'll see. I think, it is good news. The real key, though, is what's going to happen over the next few weeks. But there's a lot of big news out there. But before we get into that big news about vaccinology, let's see if there are reporter questions.
Good morning, Cody Holyoke with Channel 9. Before we start our 5-part course on the virus, I was curious, and a lot of people have been asking me too, what are you guys doing behind the scenes logistically as we await this approval for Pfizer and Moderna vaccines? Are these going to be vaccines you will be putting in arms? And just kind of peel back the curtain, I guess, for viewers, if you could.
You bet. So, and you may have already heard, Pfizer's already shipped doses to some of the centers across the country in anticipation of an approval this Thursday, which may mean we could begin vaccinating as early as Friday. In order for that to happen, though, there's been a ton of planning that goes on, because what happens is the CDC and HHS determine the number of doses by state. Then each state has its own team of folks who look at that vaccination and the number they're going to get, and they have to, with the Pfizer vaccine, they have to establish storage centers. So there are 5 storage centers in Kansas. But then, so Kansas has sent a notification out to each of those centers about how many doses they expect to get and how many doses they're allowed to keep within their own hospital and how many they have to distribute around. And there's still some discussion around some of that. So that we know that part's true. Then based upon that, each hospital or local group, for example, for our hospital or for Stormont or for Via Christi, et cetera, we prioritize who we think, based upon the number of vaccine doses we get, we prioritize those on the number of people we're going to be able to give them to. For example, in our internal facility, we're prioritizing those who are going to have direct exposure to patients who have COVID-19. And so that really means the frontline workers who are actively taking care of COVID-19 patients. And whether that's a physician or a nurse or a dietitian or a social worker or a respiratory therapist, then that's kind of, or the environmental service folks, that's how we're looking at it here. And that can actually, you can have a little bit of variability within your own hospital to meet the demands of what you feel are the local issues. And then so too, setting it up for nursing home residents. And I think there was actually a relatively bold prediction that said death in older individuals from nursing homes will be much lower by the end of January because of the first approach to vaccine. Mm-hmm. So Hawk, you've done some work on that also. Anything else you want to add to that?
Yeah, no. We have been meeting with the state as well as the county, with Wyandotte County, and really working to get everybody in those vulnerable populations on the highest tier so they can get vaccinated first, led by Dr. Williamson here at our health system to do that. So we are well positioned. We took a lot of the protocols and systems that we had in place with our influenza vaccinations, and of course, tweaked it a little bit towards this, but we continue to wait on a weekly basis for the exact details. So
yeah, and I think what's important is, let's say you're a place that's going to get 10, or no, I don't know nobody in Kansas getting 10,000 doses of the vaccine, but if you got 5,000 doses of the vaccine, what percent do you get to keep and what percent do you have to distribute? And also remember that a lot of the nursing home distribution is being operated through the Walgreens CVS combination. So hopefully that answers your question. We spent hours and hours and hours and hours and hours looking at how we'll distribute the vaccine here internally and how we start identifying people, which I think we've already started doing that. But I think many facilities have kind of gotten it down to a name and a time about when you'll get your first dose of the vaccine.
That's a quick follow-up. Does that mean you have vaccine on hand? You don't have to tell me how much, but that you have it ready to go?
You know what? I'm not going to answer that because I honestly don't know the answer to the question yet. I don't know if it's reached our actual facility here or not. So.
Okay, thank you.
Okay, other questions?
Hi guys, it's Taylor, Channel 41.
Hey, Taylor.
I agree that I know we are going to learn a whole lot this week, and I don't mean to step on toes, but I want to ask this at the outset. Obviously, one of the big topics right now is who's going to get it, who wants to get it, who's afraid of getting it, that kind of thing. What is, would you say, either the most egregious or most dangerous misnomer or piece of misinformation you've heard about this vaccine, or really vaccines in general, when it comes to convincing people whether or not they want to get one? What's the worst piece of misinformation about this vaccine or any other you've heard?
Hawk, what do you think? Yeah, the last question. Yep, so far. So what do you think, Hawk?
I don't know. I think we got an email. There's a story circulating on Facebook that it causes sterility in women.
Well, you know what? I'm just going to introduce one of our guests because we just might as well jump into that because really Kevin Alt can help us answer that question. Dr. Alt, is it true that vaccines, and especially COVID-19 vaccines, because of the binding receptor portion of the spike protein, does it cause sterility in women?
No, is the short answer to the question. That's kind of go-to misinformation. You could probably find social media posts about human papillomavirus, influenza, and other vaccines that we commonly give to young people about sterility and infertility. We don't see that in natural COVID infections, so it's kind of hard to believe the vaccine would cause that problem. Additionally, the sequence of those two proteins isn't really that similar. So, but no, that's go-to misinformation about infertility and has been used for lots of vaccines.
And Dr. Walt, what is the worst thing you've heard about as far as misinformation about the vaccine?
Well, I'm an OBGYN, so that particular rumor really hit home. I think one of the other rumors that I've heard, and I bet you're going to talk about this all 5 days this week, is why aren't we looking at transmission in these first trials? And the easy answer to that is their disease endpoints. We want to, the first thing we do with any new vaccine is find out if it prevents the target disease. We're trying to see if it prevents symptomatic COVID infections, and that's what the data that's going to be revealed over the next few weeks. The transmission dynamics and other things usually get sorted out, in future studies. But the first round of phase 3 studies will look at disease.
Yeah, I think, hey, and you got this funny big green tree behind you. It's got all sorts of stuff on it. I'm not sure what that could be. Huh? Dr. Salate, what's the worst thing you're hearing about the vaccine? Nice gray sweater.
Thank you. I think the worst that I hear is that this vaccine, especially the 2 first ones, will manipulate your genetic code, and therefore you'll be genetically altered, and they can trace you with this. There is obviously this is not the truth. There is no genetic code that will be manipulated in your genome. And I think that's probably the worst I heard.
Yeah, I've heard that. That was going to be mine, that the messenger RNA is actually a secret code that is going to transmit all your private health information to China, where something terrible is going to be done with it, and they will take your firstborn child. All those statements are not true. And I've also heard that it's going to help you grow hair, so I wanted to line up for it, as should you, Dr. Salate.
Exactly.
Okay. That statement is also not true. Hey, here's what I am a little concerned about, and this is just one concern just to raise as a point. What I hope is this, that the people who do not want to take the vaccine are not the same people who don't want to wear masks. Because if that's true, that's an entire category of people that are going to be really at the greatest risk of all. And at some point, you have to try to believe in rational science and not the mythology of the internet. So, Okay.
Well said.
Other questions, Taylor?
That's all for me. Thank you.
Thank you, sir. Anybody else out there? All right, Dr. Salate, tell us your thoughts about the new vaccine and about FDA emergency use authorization. What does FDA emergency use authorization even mean? Either you or Dr. Alt can help answer that question. And also, which of the vaccines is going to be better, Moderna or Pfizer? At least of the ones first out of the block. Let's start with that first thing. What the heck is an EUA?
So I'm going to defer to Dr. Alt as well, but emergency means there is not all information available, but there are good data that suggest that this is highly effective and not dangerous to people. And therefore, we start vaccinations and we are starting approval of these medications in an early stage. You have seen that through COVID-19 all along. I mean, most of the medications that are used for COVID-19 treatment at this point in time, they were approved through that mechanism. And Dr. Alt can add to this.
There's actually very good information about this on the FDA website. I reviewed it because I figured we would be talking about this, but it's a statutory that requirement that goes back to the 9/11 attacks and some of the biological things that happened after that. So basically, it was decided that there was a public health emergency going on, and that allowed the FDA to issue emergency use authorizations for treatments that appeared promising in the initial trial data. And that allows us to go ahead and give the vaccine before full approval, or give the biologic agents that you mentioned before full approval. Full approval will come later, but, again, we're having a global pandemic and up to about 280,000 American deaths so far.
Okay. And so talk to us a little bit, gentlemen. What's the difference between the AstraZeneca vaccine and the Moderna Pfizer one, which are somehow lumped together? Dr. Alt.
Well, these first rounds of vaccines have some unique platforms, and so the Pfizer and Moderna vaccines are messenger RNA vaccines, and then there are the next round of vaccines that might get approved under this EUA are viral vector vaccines, which there's a piece of the spike protein that we mentioned previously in an adenovirus vector. There are also in the background some protein vaccines. So, and they're all in different phases. The only two that have filed for the emergency use authorization are the RNA vaccines so far, the messenger RNA vaccines.
So, Dr. Salate, do you have a sense of which of the two it might be better? We can't ask Dr. Alt that. He's on the CDC advisory committee, so he can't tell us. But, you might have a thought. Do you have a preference between Moderna and Pfizer?
Personally, no. They both have excellent preliminary results in terms of the disease, what Dr. Alt said. Most people that still get the vaccine, that get the disease, they were actually in the placebo group of these trials. That means they did not get vaccinated with this messenger RNA vaccine. And the ones that were vaccinated, even if they got a disease, they got a very light disease, nothing that required any hospitalizations or intensive care treatment. So both of them have these similar results, and how these numbers hold up over time, we will see. But this preliminary data is incredibly positive in terms of both of these vaccines. So I believe at this point in time, it's more an issue, what can you get rather than what is better for you, because both have been safe so far and both have been highly effective.
Hawk, further thought about that?
Yeah, exactly what Dr. Salate said. I'm not sure that really there's a significant difference of the numbers that we've been able to see in the efficacy of the Pfizer versus Moderna. We still all want to see the final data points and the published studies or what they can publish and make transparent to the public. So we're waiting on that. But the initial numbers that they have given in those news stories, really, I don't think there's a significant difference between those efficacy numbers.
So, Dr. Alt, any thoughts about any concerns about the vaccines coming out too early? Are you confident in the EUA process?
I think the word that I have been using is expedited because, for the Advisory Committee on Immunization Practices that you mentioned previously and the FDA, we're going through all of our usual steps. And we started having monthly meetings rather than our 3 times a year meetings back in June. And so we've been going through all of our usual steps as far as addressing whether it's an important public health problem, finding out what the data from the early phase trials are. We're going to hear about the phase 3, the final phase trials this week and next week for these first 2 vaccines. So I think we're going through all of our usual steps. Also, if you listen into the ACIP meeting last week, we talked a lot about monitoring for safety. All the usual safety precautions are in place, plus a cell phone oriented program where in real time you put in your how you're feeling. You get text to ask you if you had a fever, if you have a sore arm, that type of thing. Certainly anybody that's listening in today, and I hope you emphasize this the rest of the week, if you're one of the first people to get the vaccine, please sign up for that program so we can have that safety data. That's real time data. There are other ways to collect that data, but that's, I think, a really innovative way to follow the safety of this vaccine and the common side effects of this vaccine.
So now you've been involved, Dr. Alt, with a lot of different experience with vaccine research. Tell us a little bit about what you've done in the past.
Well, the main vaccine that I've been involved with was the human papilloma virus vaccine that we mentioned previously about infertility. And it kind of followed the same path, these enormous 20 and 30,000 people or women in our case trials, and then a whole lot of data later. It was probably 15 years ago that the first publications about phase 3 trials came out. And I'm sure this vaccine will follow the same path. I've also, since I'm an obstetrician, you mentioned previously, been involved in influenza. I was part of the 2009 pandemic response for influenza. Influenza is somewhat similar to COVID-19, and a lot of other viral respiratory pathogens do cause worse disease in pregnant women. And so, that's kind of been my career. What I'm doing mostly now with the ACIP is policy work. Maybe I could answer the question about are we going to prefer one vaccine over another. The Advisory Committee on Immunization Practices almost never does that. But, there are several hepatitis vaccines, several flu vaccines, several meningococcal vaccines. It's much more important that you get the vaccine when it's appropriate than which vaccine you get, I think is the short answer to that question.
And Dr. Salate, the AstraZeneca vaccine has stumbled just a bit in terms of the research trial design with some different doses and things like that. What do you anticipate happening with that vaccine? And I know we're doing the trial here at KU, and some of the researchers, they report to you.
Well, it's very difficult to see the future. Right, I have a little crystal ball in my office, but I still don't see the future better than without the crystal ball. But the truth is that there are still small numbers that were reported in these news conferences for the AstraZeneca trial. And whether or not there is real differences between these two dosing that was by error actually occurring, we don't know. And I'm not so sure that that's going to be a real issue in terms of moving forward. So we just need to get more data from the AstraZeneca vaccine and then see how that works. Even those data are still promising. They seem lower than preventing the disease than in the other trials. But the important piece here again is nobody with the vaccine had actually severe disease. And that's a very important piece. What we're really going for here is to prevent hospitalizations and severe disease in people. If you get a cold or similar like a cold, that's not dramatic, in my opinion at least. And therefore, the AstraZeneca vaccine remains promising, and we just need more data. And hopefully this will come forward actually fairly quickly. Probably by the end of the year, maybe early in January, they will have more data coming up.
All right. Well, great. Well, Jill, we've been accumulating a lot of questions from the public on vaccine. Let's get started with those.
All right. If I've had COVID-19, am I eligible to receive a COVID-19 shot, and will I have to take an antibody test?
Great questions. Dr. Gall, where did that one come from? Dr. Gall, what do you think?
That is a great question. I don't know the answer. So that is usually the type of data that gets sorted out when we look at the phase 3 trial. We find out, some of the people who originally enrolled probably were antibody positive at the beginning, and look at their safety data versus the safety data of people who are antibody negative. So I think we'll have an answer to that within a week or so.
Oh, excellent. Hawkeye, any forecast about that?
Yeah, I don't know. I don't think you need to get an antibody test after you've had the infection, just because we know you've had the infection. I don't know what an antibody test will tell you. But I would anticipate, and again, Dr. All would know more than this, but we do recommend that if you've had shingles, go ahead and get the shingles vaccine to help prevent further occurrences. If you've had influenza early on in the season, we still recommend you get the influenza vaccine as well. So I suspect it'll be a similar type of thing, but we do need to wait for the final recommendations.
Okay. Will the requirement of 2 doses per vaccination delay phase 2 and 3 shots? When will everyone who wants a COVID-19 shot be able to get one?
Well, that's the million-dollar question out there. It is amazing. Okay, we're going to let everybody try and answer that one. I'm going to first turn to Dr. All. What do you think?
Well, that's a crystal ball question, as was alluded to previously. I think the data that I heard last week, of course, this changes very rapidly, was 20 million doses, in the next week or two before the end of the month, and then 5 million doses every week after that. There are 20 million people in the healthcare workers, or 21 million in the healthcare workers cohort, and about 3 million in the as far as residents of the long-term healthcare facilities. So, within a few weeks, we'd have enough vaccine to vaccinate that cohort if everything goes according to plan. But then if you start talking about essential workers and people with underlying disease, that's an enormous group of Americans. If I remember correctly, that total gets up to about 100 million. That'll be as the vaccine rolls out and as other vaccines get approved in 2021.
Dr. Salate, thoughts?
Well, I agree with what just was said. It depends on how many vaccines we have approved and then how quickly can they deliver those shots. If we have 2, that's better than 1. If we have 3, that's better than 2, obviously. And the hope is that we will have 3 soon, and then spring, summer, that's probably when we reach this, but it's not going to be tomorrow.
Hawk?
Yeah, I think that's an extremely valid concern, especially we saw, I think, last week in the news, the main news outlets that maybe Pfizer was going to be short on their initial allocations anyway. So I think that's a concern because we need to get that second dose. So will that delay you getting your second dose? If you need a second dose at 21 or 28 days, will that delay it? And what will happen if you are delayed by 3 or 4 or 5 days? We don't know the answer to that as well. So hopefully we'll get some of those answers.
How much will the supply chain of different vaccines being approved helps or affect that? For example, we know AstraZeneca may be January, Johnson & Johnson sometime thereafter, and then there's like 30 others after that. So help us understand, do you think that Pfizer and Moderna could meet everybody's need by next July, or is it going to take more or different vaccines coming into the market? Dr. Alt.
Well, that's a really challenging question. So, so I'm not sure I know the answer to that. It would just be pure speculation on my part. So I don't know. I mean, it's going to be nice to have more than the 2 initial vaccines. So that may help us depending on where these next rounds of vaccines are in the approval process.
Dr. Salatay?
I agree with that. I think we need more than 2, but that's speculation. I believe the more the better.
Jill?
Do we know if the vaccines will be an annual shot like the flu, and will the COVID-19 vaccine ever be combined with other vaccines like MMR?
Hawk, everything tells me that it's going to be at least annually.
Yeah.
Thoughts about that?
No, I would agree with you. We're thinking that way. We know that influenza vaccine is yearly. They are trying to work on a universal influenza vaccine, but that has not come to fruition just yet. Will it be a universal coronavirus vaccine that you don't need one, and it is more like MMR? I would defer to Dr. Alt for that answer, but also the answer on will it be combined. I don't know the nature of the current vaccine and technology. I don't know that it will be combined with something like MMR. Would it be combined with something like influenza? Possibly, because those are going to be given yearly. Something like MMR or tetanus vaccine, where you're only getting it every 10 years. I don't know that there will be combinations for that, but certainly would see what Dr. Alt says.
Dr. Alt, what are your thoughts about that?
Well, that's speculation as well. So it wouldn't surprise me because many vaccines do need boosters. And that's the kind of thing that usually gets sorted out after the phase 3 trial, that we actually do some post-marketing studies that determine that. I mentioned the human papillomavirus vaccine. We actually found out that we could go down from 3 to 2 doses in that vaccine. So that's something that frequently gets changed after the vaccine has been marketed.
So in other words, we learn more as we go, kind of like building the airplane while we fly it, Jill.
It takes a flu shot about 2 weeks before it protects against the flu. So how long will it take the COVID-19 vaccine to offer protection?
Dr. Salatay, you've done a lot of this. You've done a lot of research in this area. What do you think?
Well, we know you need 2 shots to be really fully effective. That means if it's 3 to 4 weeks apart, then these 3 to 4 weeks plus a little bit longer until you have the booster is really not protecting you as much as these phase 3 clinical trials suggest. These were after the second shot. So that means it's probably 6 to 7 weeks until you get really the protection that you're looking for.
Dr. Alt,
from the first shot.
I'm sorry, you bet. Dr. Alt, so really I can't take my mask off for a while yet. How long will it be before I can take my mask off?
Well, that was going to be my point exactly. We talk about Swiss cheese approach to this virus, that we have several things that may not work 100% of the time, like masks, like social distancing, like vaccines. You have to keep the whole package together. So you're not going to be able to take off your mask soon, I don't think, would be the short answer to your question.
Yeah, I think, Hawk, we have to get a whole bunch of people immunized and watch some numbers really decline, and not as much community-based transmission that are not, we've talked about, how many can one person infect, goes down dramatically if people are vaccinated, because even if you get infected, you don't get sick, you're not hospitalized. So at that point, then I think we can say it's a little safer to take off your mask. But I think Fauci once said it's going to be October.
Yeah, I think that's a good timeline and a good time point to start and end at right now when we're thinking ahead and looking at vaccinations. Plus, we need to make sure that the essential workers and our supply chains for foods and products are all set. Our first responders, our police officers, our firefighters, all those people are healthy so that their departments or their station houses aren't shut down because of illness. So I think it's important to note, but I think it will be a while before we can go maskless.
Yeah, there's actually a nice article, and I'll try and pull it up. The Swiss cheese model has been expanded this over the weekend. I saw a version of it that showed the things you can do and the things we are trying to do in public to keep you safe, and together those things try and keep you safe. So I saw the expanded version of the Swiss cheese model. So.
Okay, this next question, you could possibly insert any chronic disease because we get asked it a lot, but I suffer from severe chronic heart problems and my doctors predict I could never survive COVID-19. Will the vaccine be safe for me to take?
What do you think, Hawk?
I absolutely do think it will be safe. Again, we are waiting for all the safety data, but especially if you think about how these first Moderna and Pfizer vaccines are, it's just lipid particles with some mRNA in there. Again, it's not live virus, so I anticipate that absolutely it will be safe.
Dr. Alt, when will we see the safety data and the full set of data, for example, on Pfizer? Will that come out with the EUA authorization?
There's a hearing on Thursday for the FDA, and the companies will be presenting for Pfizer this Thursday and Moderna Thursday the 17th. And then the Advisory Committee on Immunization Practices will meet after that. But, we'll be reviewing the data as it becomes available. You can watch the FDA hearing just like you're watching this over the internet on Thursday. I'm planning on doing that between clinical duties on Thursday. So, so it's going to be readily available pretty quickly. So, in a matter of days.
And so at that hearing, we'll hear more about the safety data and we'll hear more about the full set of information, I think, of that, as I understand it. Is that correct?
Right. There's hundreds of pages in those reports to the FDA, and the ones I've been involved with, 400 or 500 pages would be pretty typical. So, there'll be a huge amount of data published. I'm sure that it'll be in a major medical journal in the next few weeks, you'd have to guess as well, since it's all been correlated. So, but yeah, you'll have information. We do have some information from the first few phase trials about side effects as far as fever and sore arms. And that happened in about 10 or 20%, depending on how you look at the data in the people that got the vaccine in these earlier trials. So I don't know that would keep somebody with congestive heart failure or one of these other chronic diseases from getting the vaccine. The question they asked me on CNN, and I just agreed, was, isn't that a whole lot better than getting COVID? Oh, of course it is. So that was the last question. They asked me a very softball kind of question. So
I'm sure you knocked that one way out of the park.
Yeah, that one I knew the answer to, definitely. So,
Dr. Salate, do you think that the vaccine will be safe? I mean, based on what you're hearing right now and what you know, how much more data do you want to have in front of you? What kind of data do you want to have before you're willing to take the shot personally?
Okay, the personal question I can answer right now. I will take the shot tomorrow, so that's easy. I believe that there is no severe side effect that we are seeing, and Dr. Alt already said, some fever, some headaches, local soreness, and that's expected from most vaccines. Even if you get a flu vaccine, many people have some side effects, at least locally. We don't see any other big side effects, at least for now, and we need to realize this is still a large clinical trial with 15 to 20,000 vaccines in people. So that's a lot in given other drug trials, for instance, that are getting approval as well. Are there potentially other side effects later on? It's always possible. But given the technology, we would expect that this is a temporary effect on the muscle that stimulates the immune system, and therefore the protection to COVID-19. So I am very positive, even with the new technology here, that we basically have seen, if there were severe side effects, we would have seen them. And obviously, we have not seen any reports of that. So I will be willing to stand in line tomorrow.
And I think I'm the same way because, 15 or 20,000, that's approximately a very big number, or 30,000. Dr. Salte, you and I have done research in patients where we alter the protein mechanism of a cell, have people inhale wild combinations of drugs, and we have 200 patients in there, and we judge if it's safe, right? I mean, so 15 to 20,000, 30,000, that's a big number.
It's a huge number. Most drugs, especially in orphan diseases, are approved with much smaller cohorts. And, I really believe that we should have seen huge side effects if they were present already, and we haven't. So that's a huge number.
Hawkeye, you ready to get the vaccine, providing that the stuff looks good on Thursday?
Yeah, absolutely.
All right, Dr. Ault, how about you? You ready?
Yes, and certainly, we're going to need to plan, and you alluded to this already, that we're going to need to plan within our own healthcare system, who gets exposed the most. I mean, I've been exposed a little bit, but I'm guessing my residents are probably exposed more than me. And there are lots of other healthcare workers, people work at KU that probably get exposed more than me. Before we leave the clinical trials, I would like to bring up, all those people who volunteered to be in those clinical trials, maybe 10 or 15 years ago, I had a master's student working with me, and we surveyed people who volunteered to be in the human papillomavirus trials. And people volunteer to be in trials out of the goodness of their heart is really what we found. And so, 30 or 40,000 people took time off of work and faced, a vaccine that may have had some questions about how it was going to work and how sort of their arm was going to be and that type of thing. So, locally, a lot of people have enrolled in those trials, and certainly they deserve our thanks.
Yeah, you bet they do. And remember, that's just one of the trials, because there's Moderna, there's AstraZeneca, there's Pfizer, there's Johnson & Johnson, and then the list keeps going on. Jill? We're
going to fit in a question from Haley for Dr. Ault. Vaccine question for the panel. How soon after receiving the second dose is it safe to attempt getting pregnant?
Ooh, there's a good question. Okay, Dr. Ault, how soon after the second dose is it safe to try and get pregnant?
I think we could do a whole hour about that, and some of those questions are going to get answered over the next few weeks as people weigh into this. But there's no a priori reason to think that RNA is going to interfere with a pregnancy. So I would say as soon as you want to would be an easy answer to that. So, it's just hard to imagine it doesn't circulate. We have plenty of enzymes that break down RNA. I was thinking maybe we should have a first or second year KU medical student to go over all those pathways for us this week. But your body is going to break it down relatively quickly, and for it to get to the fetus and cause problems with the early pregnancy it's hard to see a mechanism there.
Mm-hmm. Does the vaccine have any side effects on T cells?
T cell function, Huck?
Side effects on T cells? I don't believe there's anything untoward or deleterious against the T cells. We hope and think that the vaccine, and again, I think we're talking about Moderna and Pfizer, but also we can have AstraZeneca in this conversation too, because they are one of the other three prominent ones that are set to go under the EUA. I think they all elicit T cell responses, which we know is going to be very important, just as the B cell, the cell that makes antibodies, is important. So I think there is evidence of B and T cell responses in these vaccines.
Any other comments, gentlemen? Okay.
All right. Does the vaccine research continue after an emergency use authorization? What is involved, and how does that impact or benefit me?
Dr. Ault, this research is going to go on for years and years. Mm-hmm.
Yeah, at least a few decades, I would say. So the original people that are enrolled are going to continue to be followed, whether they were in the placebo or the active group, and for the next few years is usually the way it's done. And then frequently, even after that, there was just a report recently about the Scandinavian countries giving human papillomavirus vaccine. They've followed those people for 14 years, and the results have been good. So it wouldn't surprise me with this novel pathogen that we'll see research like that, coming up over the next few decades. There's certainly nothing keeping us from at KU from doing very similar research in this initial rollout. And that'll certainly be one of the ways we'll answer questions about pregnancy and women's health and that type of thing.
Yeah, and Dr. Salate, you've been involved with many different drug trials in the past. This is normal stuff, right, that we continue to watch things. I think Dr. Castro mentioned that people are going to be following the AstraZeneca trial for 2 years afterwards.
Yeah, absolutely. Every drug approval, even not through emergency approvals, but through regular approval, is followed after it comes to market. That is a standard procedure by the FDA, and there are ways in place to actually follow a lot of people and record if there were any issues occurring. Standard procedure.
Well, and I know as a practicing physician, we get these surveillance things that come to us. Anytime one of our patients has a side effect with a drug, we have to report it. Yep. And or at least they ask us to report it. I'm not going to lie. I sometimes don't always fill those out. I'm a bad person, though.
They're going to come after you.
They're going to come after me. I know. Well, line up.
Does the vaccine infect me with COVID-19? And am I contagious to others? Should I quarantine after I get the shot?
All right. Those are three great questions. Dr. Salate, what do you think?
No, absolutely not. This is not a live virus. This is a way to make an immune response against the active virus, but the vaccine is not the virus. It is a piece of code to express one protein, or a piece actually of a protein in your muscles to make an immune response. There is no contamination of the virus in these products, and therefore you're really not contagious because you do not have the virus. You will mount a response against if the virus were to hit you somehow, but you're not infectious and you do not have COVID-19.
Anything you want to add to that?
Yeah, well said. There's nothing to add.
What about the AstraZeneca trial? Because doesn't it use an adenovirus vector? Is that going to be different, Dr. Alt?
Affecting others if I get a mild case of COVID.
Dr. Alt, what are your thoughts?
Well, I alluded to that earlier. We do usually look at disease endpoints with these initial phase trials, and then we go back and look at transmission dynamics later. Certainly, if you reduce the viral load, which we hope these vaccines will do, you will find out later that you're less contagious. But that data will be forthcoming. It works that way for almost all respiratory pathogens. I don't know why this one would be any different. But we will find out in the next year or two.
Mm-hmm. All right. Well, team, as we wrap up today, are there final thoughts that you want to have with us, Dr. Salate? And by the way, so the world knows, I mess with Salate for all of us different sweaters all the time. So that gray sweater is nothing new. Actually, it's a very nice sweater.
Well, thank you. Yes, I think this is a game changer in COVID-19 for sure. These are highly promising data, and it will make a difference for all of us. We're getting sort of tired of being exposed to COVID-19, and you see that in the general population. There is tiredness of the social distancing, of not coming back to what we believe is a normal life. This is a chance to actually break out of this cycle. And we need to be all together in this, not stopping masking, but if we have sufficient numbers vaccinated and really getting protection from COVID-19, the normal life will be much closer than now. And it is a highly promising time. There's a lot of hope and optimism right now to get behind the COVID vaccine and put the COVID-19 disease behind us. So please look at the science, believe the science, and do not believe conspiracy theories. We'll present that to you, but this is really a breakthrough for all of us.
Dr. Alt, thank you, Matthias. Dr. Alt?
Well, I think my my final thought would be a corollary to what was just said. You know, all this information is literally out in the public. You find out about it the same time that the scientists involved find out about it. You can live stream it on the web. You can go back and look at the YouTube videos of our prior meetings for the ACIP. You know, there are a dedicated bunch of public servants and public health experts at the FDA and the CDC that are working through this process, and it's transparent, and I think that's a good thing. It's the way we always do things with ACIP. We're just, you know, under a microscope much more this time around.
Hawk?
Yeah, you know, the shingles vaccine, the pneumonia vaccine, and certainly the influenza vaccine, none of those vaccines actually cause the disease. So it's important for you and your loved ones and your children to keep caught up on your vaccine schedules to prevent those illnesses from those easily preventable diseases, prevent those secondary complications and those severe illnesses. And just as true for all those vaccines, all the vaccines that are being evaluated now for the EUA for COVID-19 will not cause COVID-19 either, just as Dr. Salate had talked about. So continue to keep up on the information from that, but also remember to keep up with your current medical providers and your current teams so that you can stay safe and get those vaccines that you need for you and your loved ones.
Tomorrow, well, first of all, thanks for Dr. Alt. By the way, Galt, Willie Galt was an Olympic class sprinter hurdler who then played wide receiver for the Chicago Bears. I think he looked just like him. And so special thanks to Dr. Alt, special thanks to Dr. Matthias Salate, and of course the Hawk here. Tomorrow, a special guest joins us. Dr. Gregory Poland is a physician scientist and the founding and current director of the Mayo Clinic's Vaccine Research Group. He is editor-in-chief of the journal Vaccine and past president of the Defense Health Board. His work focuses on understanding the genetic drivers of viral vaccine response toward greater immunity, as well as the development of novel vaccines against emerging public health threats. That sounds like what the coronavirus might just be. You know, I was trying to think about how to summarize this whole week about vaccination. And I thought about it like this. Sea of doubt, mountain of evidence. We have been swimming in the sea of doubt. Doubt about the future, doubt about who has coronavirus, who doesn't, doubt about what to do around it. But the mountain of evidence is rising above the sea. Don't get stuck on an island. There is real hope. And that hope begins this week. So listen to our program. Listen to the mountain of evidence that is growing and has already grown around our future that can be without masks and can be without COVID. This last weekend was a difficult one for the transfer center here at KU. Lots of requests, lots of patients all around the country. At one point, there was one place in Texas trying to place 14 patients with COVID. We know when we listen to the CDC and we listen to the science, we listen to Deborah Birx, we listen to Fauci, we know that we face the darkest months ahead. But real hope is right here at our doorstep. Don't get drowned in a sea of doubt about things for which science has developed an especially important thread of evidence over generations. Vaccination works. It's worked for polio. It's worked now for hepatitis C. It works for influenza. It can work for you. So you may doubt a mask and you may doubt vaccines, but remember, the one who will suffer from that doubt, in that sea of doubt, the one who will drown is you. Don't let it be you. Listen to the evidence. Our smaller communities and hospitals are especially vulnerable to COVID-19 because of the stress on the most important resource for patient care, and that's our nursing staff. They're the ones providing the lion's share of constant care and emotional support to these very sick patients. As we sign off this morning, our nursing staff at HaysMed wants you to know this. And remember, sea of doubt, mountain of hope.